I'm Susan Simpson, and in this short webinar, I'll be looking at the psychological therapies that have been considered for effectiveness in the treatment of adults with bulimia nervosa. Most of the research that was identified on psychological therapies for bulimia nervosa focused on CBT. CBT either as the treatment that was being under consideration or being used as the standard comparator in trials for other psychological therapies. In particular, a meta-analysis by Slade et al. Found that CBT was effective in reducing symptoms of bulimia nervosa compared to treatment as usual and waiting list control. And in fact, those most likely to achieve full remission are those with individual CBT focused specifically on eating disorders or guided CBT self-help for bulimia nervosa. When CBT was delivered via video conferencing or on online settings, it was also found to be effective. And there was one randomized controlled trial on video conferencing based CBT for bulimia nervosa by Mitchell et al. A range of other psychological therapies were also considered, and the ones with at least one randomized controlled trial or being considered as an adjunct therapy have all been listed below on this slide. Studies was significant differences between studies in terms of what they were measuring and what they were comparing, but in general they either compared active treatments or compared active treatments with waiting list control or treatment as usual. And outcomes generally focused on changes or improvements in eating disorder symptoms, particularly reductions in binge eating and purging, as measured by the EDE, EDEQ, and EDI, as well as other eating disorder measures. Quality of life measures were also included. So the evidence suggested that CBT is the first line treatment, and as I say, has been found effective compared to waiting list controls in a meta-analysis and treatment as usual. So this is the only therapy that at present reaches level 1, this first line evidence, and has at least 2 randomized controlled trials to support it. However, potentially between 30 and 50% of those who undertake CBT do not necessarily reach full remission, and potentially other therapeutic approaches may be considered in those cases. Clinicians might consider therapeutic models that have at least one randomized controlled trial to support them, such as IPT, ICAT, psychodynamic therapy, schema therapy, mentalization-based therapy, and or compassion-focused therapy as an adjunctive treatment. However, if these additional or alternative choices are offered, we suggest that these should be audited, that clinicians should audit them to identify whether or not they are effective, and further research obviously needs to take place in order to ascertain whether or not these second line treatments could be potentially effective compared to CBT in the future. Thank you for your attention.